Good evening to all the aspirants present today. Today class topic is metabolic disease, and the speaker that we have here is Dr. Vinod Jaiswal. He is a consultant critical care at Royal Specialty Hospital at Dubai. Thank you. Sir, you may take over. Many more students will be joining us. Thank you.
Okay, okay. Hi, sorry guys. Good evening, everyone. I hope you are doing well. Uh, can we start?
Yes, sir.
Fatma, just one question. It's a two-way communication, right? Anyone can answer or something. How is that?
Yes, sir. It's an interactive session.
Hmm.
All the aspirants are requested to kindly unmute the mics regarding if any questions you have, or you can also put in the chat box.
Okay,
Okay? Thank you.
thank you. Good evening, everyone. I'm Dr. Vinod Jaiswal. This is one of the first lecture to teach you about MRCP Part 1 and Part 2 some topics. So out of the metabolic diseases, I'll be covering today disorders of metals and metalloproteins. Let's begin, I think, without wasting any further time. The pattern is like that. There will be some questions in the beginning, and then we'll have a theoretical discussion, and then we'll come back to questions again. All right. So if you want to guys write in the chat box, you can write. 1 second. Yeah. So yeah, this is a 19-year-old man present with slurred speech, tremor, and recent behavioral changes. He has a brother who died of liver failure at 25. Slit lamp shows KF rings. Which of the following lab findings support the diagnosis? You guys can write if you want to write in the box. Or we'll come back later on and answer the questions. Okay, if you can write, no problem. A, B, C, D, E, everybody, if you can write, then we can see the answers later on. All right, we'll move in. Okay, we'll move forward. So second question, which of the following is the most common neurological symptom of Wilson disease? You can type your answers. Give some time. Okay. Wilson's disease, which pattern of inheritance and what gene is mutated? Next one. A 17-year-old girl is admitted with jaundice and ascites. She has no alcohol history. Lab shows elevated ALT, AST, low alkaline phosphatase, and coagulopathy. Ceruloplasmin is 0.15 gram per liter. What is the most appropriate next step? Okay, I think by this time the questions you must have guessed that the topic first we will discuss is Wilson disease. Okay, this is a very common topic you must be knowing, and this is also a topic in PSS exam as well. All right, so we'll discuss about Wilson disease. It's also called as hepatolenticular degeneration. Of course, the genetic disorders of copper metabolism. It's a recessive disease. 1 second. The basic dysfunction is that the copper transport is a problem, and the gene responsible for is ATP7B. So it is very easy to remember ATP, ATP molecules for energies which are produced in Krebs cycle and other cycles. Okay, and which ultimately leads to reduce biliary excretion of copper, and it gets circulated in the blood. and gets accumulated majorly in liver, but other organs as well, like brain, and they can have neurological development. Pathogenesis, sorry, the A is missing here. So ATP mediates the transport of copper, which turns the apoceruloplasmin to ceruloplasmin, and then ceruloplasmin is secreted in the bloodstream. This is a normal metabolism of copper. So when the gene mutation is there, the transport of copper is prevented. If the transport of copper is prevented, the apoceruloplasmin cannot be converted into ceruloplasmin, and that leads to excessive copper spillage in the blood. And when the copper is in the bloodstream, or when it reaches the different organs, we'll come to that also in some time, which mainly the hepatic cells. It leads to hepatocellular injury because of radical production or oxidative injury to cellular organelles. So basically, increased copper levels and hepatocyte damage results in the whole spectrum of disease in Wilson's. Actually, the free copper, not the ceruloplasmin, which is the active available copper in the blood, but the free serum copper, which is toxic to the liver cells and other tissues like brain. I hope you understand the pathophysiology. Any question here? If you want to ask, can ask, guys. No issues. Okay, so we'll look at the clinical features. First, with age presentation, generally is unlikely below 3 years of age, but from above 3 years to fourth or fifth decade of life, the Wilson's can present. Basically, manifestations of copper accumulation in different organs like liver. It can have all the manifestations from acute hepatitis to fulminant hepatic failure needing urgent transplant. So, from abdominal pain, jaundice, hepatomegaly, then signs and symptoms because of increased portal hypertension, varices, bleeding, signs and symptoms due to chronic liver disease because of copper accumulation. So most of the things of entire liver spectrum you can see when the copper is deposited in the liver. In the laboratory test, you will find low levels of serum ceruloplasmin. As you know that the copper transport is prevented, the ceruloplasmin is not forming, but though not every time the ceruloplasmin level may be low, it may be normal. But with acute liver failure, it's generally low. Then, of course, elevated liver enzymes, low alkaline phosphatase, thrombocytopenia, coagulopathy, and non-immune hemolytic anemia. Of course, you can do bedside clinical testing. So apart from that, you can do abdominal imaging, and you can find from steatosis, from hepatomegaly to cirrhosis, and all the features of chronic liver disease and acute liver failure. Neurologic involvement, the second most common organ involved is brain. Symptoms ranging from dysarthria, which is the very most common, up to 97% of the patients with high levels of copper can get dysarthria. Then cerebellar ataxia, abnormal gait, dystonia, tremor, and Parkinsonism, choreoathetosis, cognitive impairment, of course, and psychiatric symptoms also these patients can have. This is also one of the distinguished differential diagnosis in the PACES exam as well. When you get Parkinson disease or any patient with tremor, it could be essential tremor or Parkinson or with the Wilson's. This is a classical involvement you must have, guys. I don't know, in real life you had a chance to see. I think I haven't seen a KF ring. I think one time in my MBBS, I don't remember though. The KF ring is very, although not the 100% pathognomic, but yes, when the KF ring is positive, certainly you have to rule out Wilson's. Basically, copper gets deposited in the Descemet's membrane, and you can see a fine pigmented granular deposit, brown golden color on the periphery of the cornea. These are found nearly almost every patient who has a neurologic involvement, but not necessarily patient with the liver disease. And sometimes you can get deposits in the lens, so which is called as a sunflower cataract. And this is not visible with the naked eye. You need to have a slit lamp examination. As we discussed, the two common organs which are involved, the liver and the brain, there are several other organs can be involved in Wilson's disease, which are kidney can cause Fanconi syndrome, which you know that which leads to proximal tubular dysfunction, then multiple metabolic abnormalities like glycosuria, amino aciduria, and proximal and distal renal tubular acidosis, which further can cause nephrolithiasis. Myopathy, proximal limb muscle weakness, arthropathy, arthritis is very common. We cannot differentiate the arthropathy caused by the pseudo gout, which is chondrocalcinosis. It's most commonly in the knee joint. You cannot distinguish actually. Then cardiac, of course, cardiomyopathy is a high chance of cardiomyopathy. There was one MCQ also. We'll go back to all the questions again. Endocrine organs, hypoparathyroidism, gigantism, female infertility, recurrent pregnancy loss, of course, male sexual dysfunction. In the dermatological, there is blue lunulae, then acanthosis nigricans. This you must have seen in different patients, and pre-tribal hyperpigmentation, which is also seen in hyperthyroidism or toxic nodular goiter or Graves' disease rather. And as we mentioned, hemolysis, Coombs negative hemolytic anemia. So these are the mainly organs involved: the liver, the brain, the joint, knee joint, chondrocalcinosis, cardiac, some dermatological, and some renal problems, though not very common.